Hello, I'm Richard Penson, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's podcast entitled Unraveling the Options in First-Line Maintenance of Ovarian Cancer. Today's program is supported by a joint educational grant from AstraZeneca Pharmaceuticals and Merck & Co. Incorporated, Rahway, New Jersey, USA. So I'm Richard Penson. I'm a physician at Mass General Brigham and associate professor at Harvard Medical School. I'm also the IRB chair at Dana-Farber Harvard Cancer Center in Boston. And it is my delight to welcome my fabulous colleague, Tom Herzog, Deputy Director of the University of Cincinnati Cancer Center, and Paul and Carolyn Flory, endowed professor of obstetrics and gynecology at the University of Cincinnati, Ohio. Welcome, Tom.
Richard, it's always so good to see you, and it's a
Always a pleasure.
pleasure to join you today and talk about the exciting topics that we're talking about in terms of frontline maintenance for treatment of ovarian cancer with patients with advanced ovarian cancer. So great to be here with you.
Perfect. Maybe it would be helpful just to day by day give us a sense of how you use your time, because you have a lot of responsibilities, and that particular privilege really gives you a sort of wealth of wisdom about thinking about this topic.
Yeah, so I guess you're referring to the GOG role as well, which eats up another 20 hours a week or more. So yeah, it's a busy schedule most all days. Sort of integrating, yeah, I really not had the ability to separate the two roles as a professor at the university, seeing patients, doing surgery still, and so forth, and seeing patients multiple days a week from the president of the GOG Foundation, which is over GOG Partners, and then we're also the G and the NRG. So that's the government side, CTEP, NCI side of the clinical trials spectrum, whereas GOG Partners is part of the industry side. And we've had 6 approvals done through GOG trials just this year, Richard. So it's
Fantastic. Yeah.
exciting in terms of
Yeah.
transforming the standard of care. It's really exciting to be part of such a group.
And thank you for the key role you've played in bringing effective drugs to our patients. So just start by giving us a sort of introductory perspective on how you think about the patient sitting in front of you on first line therapy and what's going to come next. How do you think about maintenance therapy?
Yeah, that's a great question. So everybody talks about rolling out cases and looking at all these variables and sort of puts it into a more of I think a vacuum, if you will. In the real world, you and I have to return from this podcast and immediately start seeing patients again and to be thinking about the real world implications of what we do when a patient comes in. And so I think there's a series of decisions that one has to make pretty quickly. First one for me is, are we going to go to the operating room, or are we going to write for chemotherapy initially? In other words, are we able to think that we're going to get to optimal cytoreduction and hopefully to no gross disease? And if not, would the patient benefit then from just starting chemotherapy, hence, straightforward, without going to the operating room at that time, and then take a neoadjuvant strategy whereby we do interval debulking surgery after 3 to 4 cycles of chemotherapy? So I think that's an early decision. Either way, once you go to the OR, the next big decision to me then is, are you going to use bevacizumab with the chemotherapy? And by chemotherapy, I think you and I both know that that's a platinum-based chemo. Most of us use carboplatin and paclitaxel, taxane. So a platinum and a taxane, most of us using carboplatin and paclitaxel. We'll often substitute for the taxane if there's neuropathy or something with, say, docetaxel. But the big decision to me then, number 2, is what are we going to do with the bevacizumab? Are we going to add that, or are we not going to add that? And we can talk about some of the implications of that as we go through. And then the third decision is, once you end the chemotherapy, are you going to give additional therapy, termed maintenance therapy, for these patients? And so are you going to continue with Bev? Are you going to start a PARP and add it with Bev? If you didn't give Bev, are you going to add a PARP? Or are you going to do something else? And so I think those are the big decisions I think about in getting the patient off on their journey for advanced disease ovarian cancer patients.
Mm. And so I completely agree. I think that sequential decision, starting with the decision about bevacizumab, overall survival advantage in stage 4 disease, maybe some benefit in patients with lots of ascites. There's different sort of nuances to that. But then, exactly as you say, adding olaparib as in the Payola-1 study, or and in my practice, in patients who have a highly penetrant homologous recombination deficiency mutation, like a BRCA1 or 2 mutation, to stop the BEV and just use single agent PARP inhibitors. Some of those decisions can be complex.
Yeah,
That
some of the things we're talking about are certainly well within label, and others are slight excursions from the trials, but they make sense, right?
right.
Like you just said. I personally think that the greatest benefit for bevacizumab is at the beginning if they have, like you said, pleural effusions, large volume ascites. I think those patients really do so well because it dries those fluid collections up very quickly, which often restores their performance status, which allows them to tolerate chemotherapy and eventually surgery so much better. And so I'm pretty aggressive. I'll use the Bev cycle 1, cycle 2. I'll often use it cycle 3 and do the surgery 4 weeks out, which is within the window rather than 3 weeks out, but it allows me to get that third cycle in. I might skip one cycle then after the surgery, depending on what we did and how long it takes the patient to recover. If they recovered very well and they didn't have bowel resection, I'll often do cycle 4 with the Bev again. So I don't omit the Bev. I hear some people that hardly give it at the beginning and then try to work it in cycle 5 and 6. It's, to me, you haven't taken advantage, the therapeutic advantage, if you will, of the Bev early on, where I think it really changes the performance status of the patient.
Mm. Yeah, I think the higher complete response rates when you give bevacizumab is evidence of exactly what you're saying. I had a patient recently who couldn't get bev with their first cycle, just get a port placed, and then we would dropped it for the third cycle because it's within 6 weeks of major surgery. And you could tell from her CA-125 that when we added the bev, we really amped up the efficacy of therapy. I agree with what you're saying. Good for you. And then you get to the end of treatment and that decision point. And I tend to think of people in 3 buckets, the BRCA mutation carrying tumors and patients, the HRD group of patients, and then half the patients with their HRP tumors. How do you approach that decision point?
Yeah, so obviously one of the keys is to get tissue and get that sent off. And there's a number of vendors and in-house labs and everything else. So lots of ways that you can get this information. But I think the real key is to remind people of the guidelines that it is so important that we get BRCA status on every single one of these patients. And it's just amazing that almost 25 years into the new century, when we've known about it since the turn of the century, the importance of BRCA, that we still find patients that haven't been tested. And I find that unbelievable, but it happens. And not only does it make a difference in terms of the prognosis, but also is predictive for treatment with agents such as PARP inhibitors, but also the secondary gain of cascade testing within the family and for the patient herself, in the sense of looking for other cancers when we know the patient's BRCA1 or BRCA2 mutated. And so I can't overstress that. So yes, we get this information. We do a lot of next-gen sequencing on these advanced stage patients, so we'll get a lot of other information, some of which is helpful, some of which may be not helpful, but with the cost of doing the sequencing coming down so precipitously, it's made it an easier sell than it was maybe 4 or 5 years ago, I think, where the costs were in the thousands. We're getting the cost down significantly now to make a big difference. So we do get HRD information, and I think that's important to me. I use that very much so to help make the decisions and to understand counseling for the patient and their family in terms of prognosis, but also to and how aggressive we want to be in terms of getting her onto a PARP. I think, certainly with niraparib and the PRIMA data, we have the opportunity to put anyone, irrespective of a molecular marker, onto a PARP inhibitor in the maintenance setting. But I think that my enthusiasm goes way up if they're HRD test positive, and then it goes up even higher, of course, if they have a BRCA mutation. So we see, in terms of hazard ratios, which is the way I usually look at this data, in terms of hazard ratios, we see reductions of nearly 70% for the patients that are BRCA mutated in the risk of progression of disease or death. And as you move into the HRD, it doesn't go up very much. It's 0.43, 0.5, and generally below 0.5 that we see these patients. So we're getting a 50% or more reduction in the risk of progression or death with adding the PARP for these patients. And that's irrespective of whether you use olaparib or niraparib. And then, of course, the HRP, we only have an indication for that with niraparib from the PRIMA data, the PALO-1 data. The FDA used the subset, which was non-analytic. Even though the ITT showed a positive result, they used the non-analytic portion of that to suggest that there wasn't an advantage. Of course, they were going up against an active comparator in that study versus Bev versus placebo, which was in the PRIMA study. Nonetheless, as hazard ratios came out pretty close to 1, so I don't think a lot of people had objections to that at all. And, we can talk about the new PRIMA OS data too, in terms of how that's come out. But is there an advantage to HRP patients receiving a PARP? There is for some, right? We certainly see a hazard ratio of 0.68 for the PRIMA data in that HRP group. But the gain on that was only several months, although there are other PARP studies that have shown similar data that makes you think that there are patients that benefit, such as the Athena mono data showed a hazard ratio of, I think, 0.65 or so. And then there was the data from China that looked at niraparib as well, that also showed using a different test. So I think that for me, that getting those biomarkers is critical, and it really helps me also counsel the patient in terms of side effects and how aggressive we want to be in trying to keep them on. So someone's a BRCA carrier, I'm going to do everything I can to keep them on a PARP, everything.
Yeah. Do you have particular strategy? What's your pitch as they're starting treatment to sort of set them up for success?
Well, I think being proactive for some of the side effects, certainly antiemetics, I think, are a big part of that. Playing with the schedule a little bit if they do have any issues with food, without food. Niraparib's once a day, so you could do it in the evening. There's some people who have used olanzapine and some other drugs that are out there that seem to help with that as well. I think that the antiemetics and so forth are really key. How about yourself? What do you like to do? What do you?
Yeah, so coming back to what you said just before, I definitely, and I use sort of warfare language. It's is it a victory? And we're hoping for a 45% better chance of being alive at 7 years with olaparib in the patients who carry a BRCA mutation, and that the goal is cure. And we might not know for a decade and a half if they're cured, but it's a slightly different discussion to the HRP patient when it's a campaign, and how much is it helpful to be on treatment hoping for the best outcome as opposed to taking a break from therapy when it's very likely to have a recurrence. The recurrence is so emotionally traumatic, and the vigilance around fear of recurrence, such an anxiety driver that to start that conversation early is something I find relatively helpful. Not in 10 to 15% of patients. So you got to pick your patient. You can throw somebody into a horrible spin by sort of too much trauma with language. And then exactly as you say, so I really try to stick at 300 milligrams twice daily of olaparib or 200 milligrams of niraparib and take a break for 3 days if they get toxicity. About 17, 18% of people are going to vomit with their drugs, so like be prepared for that. I love olanzapine, like you say, ginger, wrist massage at the acupressure points, sort of get everything set up for success. And then it's probably 1 in 20 of my patients I have to accept a dose reduction, but I have to say I use a lot of like emotional topspin to cheer them through. The weariness in the second year, oh, hard work. Even with bevacizumab, I have to say, aches and pains and nosebleeds and headaches and hoarseness and just the misery is quite hard.
And with Bev, it's coming to the hospital, right? At least the other
Yeah,
folks
once every
stay
three
away from the
weeks.
hospital much more so than the Bev patients that are coming in every 3 weeks
Yeah,
for.
I am amazed how many of my patients love 2 out of 3 visits as virtual. I think that's sort of the silver lining to the pandemic is that sort of independence, home setting, local labs. We use that a lot still.
Yeah, no, that's awesome. I think that the fact with Solo One that you were quoting in terms of that 7-year data where those curves are so flat for both at that point, owing to the beauty of what you see, but the curves are so separated owing
Yeah,
to the beauty of adding the PARP. And which curve would you rather be on? There's no question when you look at that. The Solo One data is just amazing, and I think
yeah.
that you really can start invoking the word cure because we're getting out to that level of those patients should have recurred by now, many of them.
I think so. And I think I think our language is sometimes a little unhelpful. It's definitely sort of maintenance for when it's a campaign against cancer, but a 2-year therapeutic intervention to give you a better outcome, sort of not quite maintenance. So
Yeah.
exciting. Tell me what your feeling is from the Duo O and the um, key link 001 data that has just come out at the end of 2024 about
Yeah.
whether we're going to be integrating checkpoint inhibitors into.
Just when we thought we had it all figured out, right?
Yes.
So the underlying question, Richard, of course, for our audience is what is the role of adding a checkpoint inhibitor in ovarian cancer as maintenance? And what's really interesting is that um, we had so many negative trials that I thought it was pretty easy to predict they would all be negative. We had the Javelin 100, the Javelin 200, we had Imagine 50, all well done trials, well conducted trials that were negative. And then we had more recently, we had the Athena combo with rucaparib that came out negative. And not only was it negative, it looked like we may have actually been causing some harm, believe it or not, in the patients that we gave the checkpoint inhibitor to. And then Duo came out, which sort of confused us. But Duo for me is a trial that's a little hard to interpret because it seems to be missing the key arm there as to what the difference would have been of just doing olaparib versus the combination. And so we have the 3 arms there with placebo, but then placebo instead of olaparib along with durva. And that showed not a big difference. Those curves are very similar between no maintenance at all with just placebo and the durva arm. And so and then you add the olaparib, and the olaparib durva arm did great, but was that just because the olaparib was added? And then they looked at subsets, and maybe there was an advantage in those that had HRD. And so, I have trouble interpreting it. There's not enough there for me to change practice significantly. And then we just had a press release on 4 days ago from the time we're doing it, 3 days ago, I guess it was now, and reporting a positive the arm with the Pembro plus, and they had plus or minus Bev in this trial. As I remember, it was you could choose to have it or not. Um, with olaparib. And so they reported it as positive, but we have no numbers. We don't know what those the three arms look like compared to. They didn't really mention the data from the other arm. They just compared it, I think, to arm one, which was chemo, followed by no maintenance. And there was no pembro given with the chemo in arm one or the control arm. So I don't know. What were your thoughts on it? I mean, it was a little hard. I tried to read the press release a couple times,
Yeah.
if I could sneak some better data out of it.
Right. No, I suspect it's a complicated study, and bevacizumab, um, that sort of option to use bevacizumab, I think is going to make interpretation really difficult. And
Yeah,
teasing
they did
out,
stratify it by it, and then they also looked at the was it the CPS score greater than 10
mm,
versus under 10 was another stratification factor
mm,
predicting you know the PDL1 response. So it's going to be interesting.
it is. So what I tell patients is that we're excited that at some point there's going to be a breakthrough in understanding the microenvironment and the standard treatments like pembrolizumab, um, and sort of unlock it for ovarian cancer, or breakthrough things like the bispecifics or CAR T cells. But we're not there yet. And so it was an encouragement, a little bit of a signal that the work is worth it to try and get benefit, but not a clear signal yet, was my sense.
Yeah, but
Um,
it's exciting that at least we have a positive press release,
yes,
and
yeah, yeah, no,
it
I
could
hear
be
you.
really awesome data. So I'm looking
Right.
forward to
Yeah.
seeing that data
So
set. Very much.
put on your academic hat and and explain to me why it is so hard to get quality of life data to sort of numerically evaluate the patient experience. So it's tough with nausea and fatigue and a sort of fear of leukemia, and yet, boy, we are like it's really hard to quantitate the quality of life experience. Um, Bav Pathuri presenting the Prima data and Michael Friedlander the Solo 2 data. Beautiful science, but amazingly hard to show differences between placebo and PARP inhibitors.
Yeah, I think that there's a couple of dynamics here working maybe against one another, but one of the things that I think is still true, and we know people that do nothing but this, right, Richard? That they've
Yeah,
spent their whole career really dedicated in terms of their academic pursuit, looking at quality of life and patient-reported outcomes, and trying to better understand the context of these drugs in the patient's life in terms of how that is affected. I still, having said that and giving them great respect, I still think that some of these tools are a bit too blunt and don't capture some things. I don't know if patients are reporting and they have fear of reporting that some of this information could be used to reduce their dose or change them, from the treatment they're on. The example I always use, it's a very crude, but my NP or my nurse will come in and say, "Oh, Mrs. So and so's in, and she's got 30 complaints and it's terrible." And I'll be looking and doing everything. And the last second, their CA 125 came back, and oh, good, I'm going to tell her. So I go into the room and I say, "Hi, Mrs. Jones. I understand you got a lot of concerns. I just want to let you know, though, your CA 125 went from 450 down to, 86." And I go, "So start telling me about your problems." "Oh, I'm fine. I just want to get over to infusion. I'm fine. I just had a few little itty bitty things, don't worry about it." So it's
yeah,
very interesting how the patient tries to look at that data and how we're going to use that data. But getting back to what you talked about, I do think that we've seen that, and then I think you have a couple of forces working against one another. One, you undoubtedly are going to have more toxicity as you add drugs, right? All these things have some side effects and toxicity. And with the PARPs, we can see GI, we can see heme, we can see, we always worry about long-term things like MDS and AML, but fatigue is a big one as well, right? And so the other thing, though, is their disease may be at bay, or being, those that had a PR to chemo may actually have disease that continues to go away, which is going to make them feel better. So they have one thing making them feel a little worse, another one maybe making them feel a little bit better than the patients that aren't on the PARP. And so I think it's hard to look at this data sometimes, but you're right. We've seen some really nice pieces. The confidence intervals on almost all these studies seem to overlap, though, in terms of whether you're on the intervention arm or you're on the control arm, which is very interesting.
Mm.
Or if we do see a difference, it's very early on with the PARPs. And once the physician and the patient sort of get into that rhythm of how to use this, get to the right dose, et cetera, we no longer see a statistical difference from the control arm
Mm.
in any way. So I think that, the big thing is trying to figure out these symptoms.
So I think that I don't want to speak for Alexi, but Dr. Wright from the Dana-Farber is not so confident that refining the instruments, the actual questionnaires, to evaluate a highly subjective experience for patients that is so variable. Biology is variable, and our sort of psychological interpretation of symptoms is highly variable, that her strategy is just to make the fatigue better. And she has this really cool randomized trial called Revitalize that's being rolled out during 2025. And the goal is what she calls acceptance and commitment therapy. It's a telehealth intervention. And it was piloted at the Farber and at Penn, and they could show an improvement in fatigue, which is fantastic. And it's a little bit like you said with the CA125. There's some things you can't change, and there's some that you can. And so the acceptance is just that sort of Zen sort of wisdom, sort of strength to cope, and then understanding fatigue, sort of limiting unreasonable things, working at sleep, diet, exercise to get your strongest. I love what she's doing. It's really very good.
It's exciting. So she's starting the Revitalize trial, right? That's the
Right.
name of it. It's going to start this, I guess, in a few weeks, right? In
Yeah,
June.
soon. Yeah, it's really good.
Wonderful.
Fabulous. So, unfortunately, it's time to wrap up our discussion. So, let me summarize what we've discussed today. The whole understanding of switch maintenance therapy, concurrent bevacizumab for those where there's an overall survival advantage in stage 4 disease, and probably benefit to other groups of patients, and then the addition of a PARP inhibitor, olaparib and niraparib, the different subgroups conferring different degrees of benefit, but really a paradigm shift in terms of, especially for the patients carrying or tumors with a BRCA1 or 2 mutation, a tremendously better chance of being alive 7 years later, 45% better with olaparib, quite fabulous. And then quality of life and our attention to those significant symptoms, mitigating fatigue, really important. So to receive CME and CE credits for today's program, complete the post-test and evaluation. You'll be able to download and print your certificate immediately upon completion. Remember, this is the 5th of a 6-part podcast series on gynecologic cancers. And next month, I'll be hosting a discussion of exploring the rapidly evolving landscape of the options for treat cervical cancer. And I hope you'll be able to join us. We'll be archiving this and future podcasts in the series on the Oncology Hub at cmeoutfitters.com, where you can also find a number of excellent resources for clinicians and patients. And again, thank you, Tom.
Thank you, Richard, for having me. Great
Thank you, Tom, for joining us for a very important discussion. And thank you to our audience for tuning in today and for providing the very best care for patients with ovarian cancer.